Good. So I'm going to talk today about digital technologies in public health crisis. So as I mentioned, I'm an engineer that had some training in public health, and right now I'm very into that kind of that intersection of technology, society, and policy. I'm representing here different organizations. One is MIT Critical Data that I'm going to speak at the very end, and I'm also part of a couple of other organizations that are Clubers de Ciencia Colombia and Cientelab. They are both working on a STEM education in Colombia. So I wanted to start with this slide because this slide's coming from, and this diagram is coming from, I think it was October or November 2019. That was right before the pandemic. We continue talking about this concept of One Health, that is the interaction between human environment and the animal health, and how animal health can impact human health and environment can impact human health as well. And we are seeing that with the current climate change crisis. What is happening with the world, the colonization that we have right now, and all that impact that is, I don't know why cities, and all that impact that the climate crisis is, that is affecting all of us, is also affecting our health. And I think a lot of the conversation when we are going to the climate change meetings, for instance, COP27 that just happened, well, maybe this year it's more, but from previous years, there was not that much about health. I mean, yes, we were talking about different different disasters that could happen with climate change, but not that connection and direct connection with health. So I think that this was presented at that time as a good approach to manage health crisis from that perspective of understanding human health and environment. So that One Health perspective, I want you to keep that, because for me is one good explanation of what happened with COVID and how, even though we were talking about this, months before COVID, we were not prepared for that. This is a very recent slide. I think you have seen this slide in all the presentations about COVID, but this is the last one that I could just screenshot from the Johns Hopkins dashboard that is talking about the total number of cases, the total deaths. So the idea here is to show you what's the bottom of the COVID-19 pandemic, what is the number of very significant number, almost 7 million of deaths that we have had so far in the last 2 years when the pandemic started in beginning of 2020. We've seen a lot of kind of what we were talking about, the peaks, the many peaks that we had during the pandemics. I mean, the relationship between those peaks with the number of deaths as well. And then by the end of 2020, it's amazing how we had that investment and that kind of social commitment to vaccinate a lot of people. So we had a huge amount of vaccines 2021, but now we are seeing less and less. Of course, we are getting some immunity. People is kind of less less interest in the topic. I don't know, it's seeing that COVID is not affecting them that much, or at least that's what I'm kind of perceiving from many people here in Colombia. And that's why the number of vaccines is not as it should be, because even though, yes, we need 1 doses, 2 doses, I mean, there are new strains and it's recommended that we continue taking the doses. But the same happened with influenza, the same happened when a disease, as happened with COVID, affects the world in a way that, I mean, right now COVID is more, it's a disease that is going to be there, but it's not having that direct impact in human deaths and in the number of deaths that happened, for instance, in 2021. So I just wanted to show that impact of COVID-19. And I wanted to also bring the importance of digital technologies and how the digital revolution, even though, I mean, we were talking about this, we have been talking about this for the last 10 years, but recently we see more and more that almost everyone in the world got a smartphone. Uh, but that's not counting a lot of people in different parts, especially from the global south, vulnerable communities, that they don't have access to those digital technologies. So yes, we have a digital revolution from one side, but we're leaving a lot of vulnerable communities outside. And that's the reason, and also because of the pandemic, that we started talking about the digital access as one of those social determinants of health. And I think that's very important because right now, when we move to, I mean, from public health to population health, and when we talk about global health, it's a lot about how we can deal with the social determinants of health, which are those determinants that affect our health in the future. Maybe are not affecting them right away, but affect our health in the future in terms of economy, access, in terms of housing, in terms of, for instance, what's the built environment where I'm moving. So I think it's important to notice that the digital revolution was there, but especially for healthcare, the pandemic really accelerate more of that implementation of digital technologies in the healthcare industry and the healthcare sector. And we see a lot of articles. This is an article coming right at the beginning of the pandemic in 2020. It was like in June of 2020. They were talking about all those interconnected digital technologies used in the public health response to COVID-19. And here you can see a lot of technologies, for instance, computer vision drones that were used at that time to bring medicine to certain parts of the world. Some smartphone apps. I mean, we saw a lot of those in terms of contact tracing apps. We are going to cover a little bit more about that. Chatbots, system reporting apps, telemedicine. We see a lot of machine learning and natural language processing that was applied to those smartphone apps. And when we talk about technology, sometimes we have sometimes and most of the time we have a lot of intersections. So even though we talk about computer vision and smartphone apps, machine learning is kind of transversal to those two. Then we have a lot of SMS and instant messages. Again, for those that perhaps didn't have a smartphone and they have an old phone with only SMS. So also from public health agencies, they were trying to be as inclusive as possible. And that's why they were sending a lot of SMS messages. But also something that is very important is that social media and online searches became an important conversation during the 2 years of the pandemic and will continue to be so, because I think for all of you was clear that even though public health agencies were trying to bring some very clear messages of what we need to do in order to avoid the contagion of the disease, we also saw a lot of false news, misinformation, and actually we were talking from public health about not only pandemia, but also an infodemia. So we were dealing with two at the same time. One that was because of the virus, because of an infectious disease kind of outbreak and pandemia, and the other one that it was a lot of misinformation that was having also very huge impact in the life of many people worldwide. Yes, we were talking about wearable sensors. That's kind of what is normal, or at least what we see more in the healthcare sector. The digital diagnostics and genomics also advance a lot, and we see more and more of the. I mean, at least for the last year, of those point of care testing or self-testing devices, and the visualization tool that is kind of the dashboard that I just showed you about how the pandemic hit. So that's kind of another tool, another technology that was used a lot. It was not that well known before the pandemic, but it's used a lot, and I think it's going to be there for a long time. Good. Let's do like assume a little bit about what happened in terms of machine learning and natural language processing, which is kind of more of my field. And I also found this very interesting report from the OCDE, talking about the accelerating research in terms of open data projects and distributed computing for AI-driven solutions. And they were dividing that like in four main areas in terms of detection, prevention, response, and recovery. If we go to detection, then we see a lot of these early warning devices. Again, using, as I was explaining before, using, for instance, dashboards, how they were taking data from non-traditional data sources. For instance, social media and data from Google searches. And with that data, they were kind of providing those smoke signals, saying, okay, there is something that is not working well here. We are finding a lot of people in Wuhan, and this is a real example that happened with Blue Dot in November 2019. That there were a lot of people in Wuhan is asking Google for flu-like symptoms. And that was kind of a smoke signal. Okay, there is something that is happening there that we are not seeing. And that was before WHO declared the pandemic in June, February 2020. We see a lot of in terms of diagnosis as well. And I think this is something related to what I'm doing right now, more into the radiology part, and is that the pattern recognition that we can have in medical imagery and symptoms data. So a lot of CT scans as well that using machine learning, using AI, we were able to diagnose and differentiate when we were having COVID compared to when we were having more like pneumonia, other type of respiratory diseases. Then we have prevention. In terms of prevention, we can do prediction, surveillance, and information. In prediction, I think that happened a lot and happened particularly in Colombia as well. There was some applications, visualization tools that were telling you what's your probability of infection. Taking different sources of data in terms of what's your mobility, also what comorbidities you have, what other diseases you have, that is not only telling you whether you could get infected, but also whether that infection could be a severe infection or not. And I think in terms of prediction, I would like to hear from your experiences later on, how you saw that. I mean, if you also had similar applications, because for me those work well, but there were some issues with some privacy concerns I'm going to talk a little bit later. And that's very, very connected to surveillance. So we have one that is prediction, more that kind of that personal risk, and the surveillance, which is more like what we are talking about, contact tracing. And I'm gonna have like a short conversation later on about how we are doing a proper contact tracing, and also for the future, how contact tracing should be done. And then we have the information in terms of prevention. Again, we, from public health agencies, we were always trying to provide the evidence in terms of what could work. I mean, again, that evidence is changing more in a pandemic, because we are building that evidence at the same time. So that's why, and I think that's one of the main reasons why misinformation was so strong, because they were seeing though as scientists saying one thing and the next day saying, okay, I mean, according to the new evidence, maybe we shouldn't be doing that much of, I don't know, washing our hands, which it's important, but not as we were perhaps at the very beginning kind of promoting that, particularly for COVID, of course. I mean, for other diseases, washing hands is always very important. So in terms of that information, how we can have also personalized news and moderate the content that some specific population were receiving. In terms of response, again, for delivery, as I mentioned before, trans, and also in some hospitals when it was not possible to see some patients, they were even having some robots that were kind of with the patient, I mean, in the patient bedside next to you, and it was a way of also of humanizing healthcare, connecting that person with their beloved ones. In terms of service automation, a lot of chatbots. I think that was kind of our daily life, connecting through WhatsApp or different um, um, other media, and then we have chatbot that were replying to us all the different questions that we had in terms of symptoms and so on. And then I think in terms of recovery, there are a lot of applications as well that is tracking that economic recovery using, again, different data sources. And one application is that of the WeBank. So we see a lot of research on that area, depending on kind of a specific sub area, how machine learning was helping with the pandemic. And this is maybe a complex kind of graph. I want to explain it like very fast because I don't want to spend too much time here. That is talking about that contact tracing that was used for the pandemic, but that could be used later on. So here we have different types of data. We have the population level data and the individual level data. Again, all that we just explained about web-based epidemic intelligence tools, syndromic surveillance, population mobility analysis, and in terms of the individual level data, more in terms of symptoms reporting and citizen science apps, contact tracing apps, and self-testing support and connected diagnostics. But that information all the time, and I think one of the main messages that I wanted to bring with this graph as well is how we are preserving privacy. We are dealing here with a lot of information, and most of the information, especially when we are talking about individual level data, is protected health information from the HIPAA compliance. I mean, we are talking about the health regulation in the US. It's a very kind of important type of data that we don't want to release. I'm seeing that there are a couple of. Okay, good. And then we have, from that data, we have a lot of analytics and modeling. We have also more data visualization tools that help us with the public health decision making. So again, all that information, and we are going to explain about one specific contact tracing app in Colombia. What happened after that in terms of the analytics and modeling is helping us with the decision making. But then we have other type of data. We have the data coming from the digital clinical case management. And here we saw a lot of telemedicine, for instance, electronic healthcare records. That one of the ideas with the pandemic and that I'm kind of encouraging more and more as part of our organization is the importance of sharing data. So electronic healthcare records, important information that was just stored in the hospitals that was not released, of course, because of the privacy concerns, but that for a proper response to the pandemic, it was very important to have that information. And then we have the other that we have been discussing, that is the digital public communication in terms of social media, how we manage this information, and how we tailor and target public health information, which is very important for, again, in a public health crisis, how you deal with that information in a way that people is well informed. And again, all that population level, individual level, digital clinical case management, and digital public communication are sources of data that will come here to more like that analytics and modeling component, and eventually will help you with the public health decision making. So again, I just wanted to have the graph of the different type of information that you can manage in a public health crisis, and particularly with infectious diseases. I think that's important to kind of differentiate. So let's see very briefly about this application. It's an application that was used by the mayor the mayor's office here, the Medellin city in Colombia. Medellin, the second largest city in Colombia, you might know. The platform was very interesting. I think the platform was acquiring some data using both the phone, but also using a web app, data that was from you, but data also coming from your family. And the interesting part of the platform, I think, would one of the main kind of um, positive messages that they were trying to deliver is that, okay, we are going to manage some resources depending on the information that you are providing us, and we are kind of also providing you with some, I don't know, let's say some social support, some social services, or some kind of in your house that you have some food delivery or things like that. So it was like very well received, and actually it appears in different media, The Economist, The Washington Post, and New York Times, talking about how Colombia, and our second largest city, was controlling the pandemic. But then you find a lot of issues with that as well. So we started to quarantine some specific neighborhoods here in the city. And when we see the neighborhoods, those neighborhoods were neighborhoods with more vulnerable communities, with people with informal economy, that they were really in need of going to the streets and working on the streets for having their daily kind of surviving meals. So it was very hard in a way that the application, and that was presented by Fundación Carisma in a huge report that, I mean, they were not only talking about this specific application of Medellin Me Cuida, but also other applications in the country, and how those COVID apps were actually impacting human rights and were leaving some vulnerable communities in more danger, and were also not integrated in a way that were properly kind of responding to the pandemic. And this is the last slide, but I think it's a very interesting slide coming from JAMA from this year that is showing us, okay, now that we had COVID-19, now that we had kind of the experience of very different technologies that we talk about, how we should think about the future. So very connected to Gigi question about, okay, what is needed now that we kind of go back and see what happened with COVID-19. So first of all, they are talking about the team in terms of that collaboration between different stakeholders. What happened in the case study that I just presented about Medellin Me Cuida and that application is that the application was good for the city, but when we were talking about that connection, the connection between the city and the national, and they also have different apps, there was no communication between them. So again, the stakeholders were not aligned. And we should promote that flow of data to improve population health. So you see a lot of people, I mean, kind of putting the information in the application here for Medellin, but putting the same information in the application that they had from the Colombian Ministry of Health. Transparency and trust, and I think this is something that is very important. And you will see this in the other projects that you currently have in terms of migration and camera surveillance. That is, I mean, if you really would like the community to adopt the technology, you really have to build trust with them first. So the digital health approaches, as we were talking about them, they must preserve the rights to privacy and consent, and they should be clear in the different terms of reference, in the different like small the fine print that they were presenting to you. The technology that we talk about that, and it's very important that they collect very high quality data. Equity, I don't like this concept, but they are talking about how we really need to act all the time to decrease inequities in digital health capability. and access to individual, local, national, regional, and global levels. And again, this is all about this digital inclusion. And as I mentioned before, now that we consider digital access as one of those social determinants of health, how when we deliver new technology, we really think about those vulnerable communities that maybe they don't have access to that specific technology. And the transformation part, which is how we enable and how we empower people to make those changes. And right now, and actually that's a class that I'm giving next to this one. It's a class about digital transformation, and that's actually one of the main topics. Is how we, when we are talking about digital transformation in health, we move to that social aspect and we move to that cultural transformation. Because if you don't have that transformation, I mean, you can bring the technology that you want, but the technology only get you so far. Good, and that's what we are trying to do at MIT Critical Data. This is a consortium of different labs and organizations, both at MIT and worldwide. We have some data sets, we have different education initiatives, and we have some books as well that we are promoting in terms of a proper implementation of data science in healthcare. But I don't want to explain a lot about this, but just to show you a little bit about what we are doing. Great, muchas gracias. Thank you so much.